accuracy of the test depended on the context. If the pretest is 0 or the pretest is 1%, then even high-quality testing, 99% sensitive, 99% specific tests, don't help because you need a reasonable pretest before your test can help. But where does that pretest come from? So in a previous video, which I will link here as well as in a comment below, I went through Bayes' theorem and how to calculate the accuracy of a test, trying to figure out, once we have a medical test or any kind of test, how could we know how likely it was to be right, how likely it was to generate false positives or false negatives. Briefly, we said that if we were scanning joules, if we had a joule scanning device, and we took a bag of 10,000 joules at the factory, 100 of them were real, and we ran it through the device, we could quantify after the fact how accurate the device was. We could quantify how well the device had done in making sure that real diamonds were labeled as real and fake or lab-made diamonds were labeled as fake. And each of those would have an error rate. So in this case, I've chosen 1% as the error rate in both cases, and we call that the sensitivity or the specificity. So the sensitivity is how many times real diamonds are called fake. That's an error. That's called a false negative error. And false positives are how often fake diamonds or fake disease is called real. That's the false positive rate. So sensitivity is the false negative rate, specificity is the false positive rate. Once again, the errors are noted here in the middle. So we also considered that just picking a joule at random from the bag, there was some probability that that was real. We could say, well, I have a 1% chance that this randomly chosen diamond is real. We called that the pretest probability because we hadn't run any tests on it yet. That corresponds a bit to a patient walking in with a certain number of symptoms. If a patient walks in with a sore throat, there's a certain probability that they have strep throat. If they are a patient with sore throat and cough, that's a different probability. If they're sore throat and cough and no fever, that's a different probability. But we haven't run any tests yet. We also realized that the accuracy of the test depended on the context. If we gave it a no-win scenario where there were no real diamonds in the bag at all, then when the device said it was real, it was always wrong because that was always from error. The 100 times that the device said that it was real were all false positives. In a 1% chance where there's 100 real diamonds out of 10,000, then the device was right 50% of the time. And in a 10% chance where there's 1,000 real diamonds out of 10,000, then the device was right even more often. When the device said that it was real, it was right 92% of the time. So from 0% to 1% to 10%, the accuracy of the device overall went up, even though the device remained unchanged, because the context of testing affected the accuracy of the results. So we realized that the math is annoying and that evidence, testing, diagnostic evidence, increases our certainty from the pretest probability, 0, 1, 10%, to the post-test probability, 0, 50, or 92%, respectively. And we realized that if the pretest is 0 or the pretest is 1%, then even high-quality testing, 99% sensitive, 99% specific tests, don't help. You only get up to 50% at best because you need a reasonable pretest before your test can help. But where does that pretest come from? Where do we derive in medicine that pretest probability, the prior probability, we call it, also known as the context? Well, unfortunately, pretest probability pretty much comes from physician opinion. So I'll rely on that previous example. Imagine you're a jewel merchant, and you're trying to tell the difference between real diamonds and fake diamonds. And one guy comes to you wanting to sell jewels to you, and he's a worker at the lab diamond factory. He actually works there. And he's nervous and shifty, but he's explaining these aren't diamonds from the factory where he works. These are diamonds from his grandmother, he promises. You've never met this guy before in your life. He just happened to remove them from the necklace they were on, and they all happened to have the exact same size, color, and clarity, but they were his grandmother's diamonds, but they're really real, he promises. He promises. How likely is it that he's telling the truth? Now, the other dealer comes to you as a certified gemologist. You've worked with him before. He works for De Beers. He's selling them at an appropriate price, and he has an assortment of sizes, cuts, and clarity. How likely is it that he's telling the truth, that his diamonds are real? That's where the pretest probability comes from. In the first scenario, you don't trust that this is an honest dealer. You think he is a dishonest dealer, and your pretest probability is very low. So even if you run it through that device, and even if the device says it's real, you're still very suspicious. So you think this guy has a 0.1% pretest chance that those are real. So even if the device says it's real, the probability is only 9% if you want to quantify it. You're only 9% certain that this is a real diamond, even if a very accurate test says that it's real. It's more likely that the test is wrong because the context is so unlikely. Similarly, with an honest salesman, basically if the device says that it's real, your probability is 100% because the context is so certain already. So in medicine, physician intuition, physician familiarity with how diseases look, sound, operate, that creates a fuzzy logic pattern that creates a sense of probability for certain diseases or illnesses. Out of all of the diseases that exist in the world, how many of them come in with a sore throat? How many diseases in the world have cough as a symptom, as a first symptom, as a main symptom? How many diseases in the world have cough that lasts longer than 6 weeks as a symptom? That's a different set. How many illnesses have runny nose as a symptom? How many illnesses have runny nose with fever as a symptom? How many have runny nose with fever that gets better and then gets worse again after 2 days? Each of those stories makes certain diagnoses more and less likely. And that's what we call an illness script. And our ability to match illness scripts in our minds is where the pretest probability of diseases comes from. So if a 5-year-old comes in with high fever, sore throat, pus on the tonsils, swollen lymph nodes, and no cough, they have a very high probability of having strep throat. If a 45-year-old comes in with a sore throat, cough, no pus on the tonsils, no fever, no swollen lymph nodes, they have an extremely low probability that sore throat is because of strep throat, no matter what the test says. And this is where we get these false ideas, because often that 45-year-old will get a strep test and it'll be positive, and the doctor or nurse who doesn't think very clearly will say, "Oh, you have strep throat, here's some antibiotics." No, they don't. You have a false positive test. And you shouldn't have run the test in the first place because the context was so low that that test would give you false positives more than real positives. That's a real scenario, by the way. There are some helpful scoring systems. So the example I gave with the sore throat, that's the McIsaac scoring system, and that will give you a fairly exact probability based on the number of symptoms: cough, fever, swollen lymph nodes, pus on the tonsils, and age. And for each one of those, you get a point, and that changes the probability. And it's been well validated in both adult and child populations. But that's relatively uncommon. Usually it's that sort of physician fuzzy logic, or it's our understanding of how prevalent the disease is in the population. So we saw that with COVID, is that early in the pandemic, there were not very many cases. They seemed serious, but they were very sporadic and widespread. And the tests were not very accurate because the disease was not very common. There were a large number of false positives. And at that time, it seemed most prudent to err on the side of caution and have even the false positives quarantine. knowing that we were quarantining people who probably didn't need it, but we were trying to keep it from spreading. Later on, the exact opposite problem happens, is that in some places there's 10% prevalence of COVID, and the false negatives are actually quite high because the antigen tests aren't very accurate, especially after the evolution of Omicron. And so multiple false negatives are expected because there's very high pretest probability and the test accuracy is not very high. So these things that we see happening are expected. Similarly for mammograms, I talked about that in the first video, where if you're testing 20-year-olds with mammograms, you're going to get a ton of false positives. If you're testing 60-year-olds with mammograms, you'll get much fewer false positives. So as I said, for COVID, the prevalence of the population and how well the symptoms match the typical illness script. That's one example of where pretest probability comes from. So what are some of the implications of this? And I think this is the really fun section. What has happened by switching our context here? It's an important shift, but relatively subtle. What's happened is we started by talking about probabilities, or we started thinking about probabilities as facts about the world. The probability that someone has COVID, that's usually how we talk. When we should talk about what is our certainty level? What is the probability that our belief they have COVID is correct? That's an important distinction because probabilities about beliefs can be updated. And we are not really talking about the world. We're talking about our opinion about the world, our belief about the world. And with Bayes' theorem, that's the true revolution, is that instead of thinking about our beliefs as right or wrong a certain percentage of the time, so I could say that out of all the patients I diagnosed with COVID, I was wrong a certain percentage of the time. Or I could say that my beliefs about the patient have a certain percent certainty. I'm 80% certain you have COVID. I'm 90% certain you have breast cancer. And fresh evidence, medical testing, new symptoms, the progress of the patient over time, the way they respond to medications, gives additional information that updates our belief, that updates our certainty about our belief about what's going on. It's also true that each and every scientific study that is done acts as an evidence or as an update to our beliefs. So if I want to test the theory that astrological sign affects heart attack risk, then I could do that, and that test would update the belief. But if I already think that's very improbable, then even a very high quality study that is very well done and very accurate will only update that belief a little bit. Whereas if I already think it's very likely to be true, then a very well done, a very accurate study will not convince me very much. It might lower my certainty. The beauty of this way of thinking is that over time, after study comes out, the beliefs of someone who started very doubtful and someone who started very convinced will eventually converge. Because each study updates the certainty of their belief over time, and both people converge on high certainty beliefs that correspond quite well with the truth. And that is actually how science works. But the key aspect of that is time, is repeated studies, not one study that you find convincing. Anyway, that is where pretest probability comes from. That's how we use it in medical science, or how we should use it. Most physicians actually don't understand this correctly. And hopefully this will increase your ability to interpret medical tests accurately.